This is Endocrine Feedback Loop. I am your host, Chase Hendrickson, and welcome you to this Journal Club podcast series brought to you by the Endocrine Society. Thanks for joining us as we explore an important article recently published in one of the Society's clinical journals. Hello and welcome back to Endocrine Feedback Loop for our 60th episode and the end of our 5th season. We appreciate each of you as our listeners and want to say a special thanks to all of you for joining us in these discussions over the past 5 years. For this episode, we look at a study in the JCENM that reports the benefits of older weight loss medications in a population of women with PCOS. Much of the attention today in obesity medicine focuses on GLP-1 receptor agonists. However, these medications are not treatment options for many of our patients, so we thought this paper asked important questions that you all, as our listeners, would want to know the answers to. As usual, we will give you our thoughts along the way, including any differences we may have with how the authors interpreted their data. I host the Endocrine Feedback Loop podcast, working as a general endocrinologist and medical director at the Vanderbilt University Medical Center in Nashville, Tennessee. Back with me today is this episode's regular contributor is Na Shin, one of the podcast's expert in obesity medicine. She comes to us from the University of California, Los Angeles, where she founded and runs the program for reducing obesity in their ambulatory clinics. Her research interests include quality improvement and expanding obesity care access. Our guest expert today works alongside Na at UCLA. Stanley Kornman has been at UCLA for many years, holding several important positions throughout that institution. Importantly for our purposes, his clinical and research work focuses on reproductive endocrinology, including PCOS, and he is well known to many of you listeners for his publications and talks in this area. So, as usual, the perfect pair of endocrinologists joins me to help us understand this research. As is also always the case, everything we discuss will be our opinions only and not necessarily those of our respective institutions or of the Endocrine Society. Today, we review Topiramate added to Metformin for obesity control in women with polycystic ovary syndrome, which is a forthcoming article in the Journal of Clinical Endocrinology Metabolism. Lucas Bandeira Marchesan at the Universidade Federal do Rio Grande do Sul in Brazil served as the first author for this paper. I will now hand things off to Na. She will go through the author's introduction to review the main points that they make and to get Stan to give us insight into a few key concepts. Na.
Thank you, Chase, for that lovely introduction. Glad to be back. So let's dive right in. The authors start by stating that PCOS is commonly associated with obesity and that obesity exacerbates cardiometabolic risks and impairs fertility in this patient population. Topiramate is essentially acting anti-epileptic drug FDA approved for the management of epilepsy and migraine. However, it has been commonly used off-label for obesity management. When combined with Metformin, it was FDA approved in 2012 to treat obesity. So Stan, do you ever prescribe Topiramate off-label for weight management in your clinic?
No. However, I did have patients on Metformin, and I never took them off if they were happy with it.
Metformin, on the other hand, has cardiometabolic and hormonal benefits in women with PCOS and obesity, oftentimes prescribed in this patient population in conjunction with birth control. No randomized studies have looked at the combination of metformin and topiramate for weight loss and cardiometabolic metrics in women with PCOS. So this study's aims were to evaluate the effects of topiramate added to a metformin regimen on weight control, as well as on clinical cardiometabolic and hormonal parameters in women with PCOS and obesity or overweight and associated cardiometabolic features. All right, I'll turn it back to you, Chase.
With that, I think we can understand why we want to understand a little bit more about this and see if this may be a medication with a specific population in mind that may be of benefit. The authors describe their work here as a randomized double-blind placebo-controlled study. We don't look at those often on this podcast. We are far more frequently looking at observational studies. So we'll just quickly remind everybody, I think everybody has in mind, well, RCTs is the gold standard. If any data we get is going to be reliable, then it's going to be data that comes from RCTs. I think it's helpful to remind ourselves why that's the case, particularly as we contrast it with observational studies and the problems that we run into there. And I would describe it as really two key issues that you can overcome with RCTs. And one of those issues is the challenge with confounding, and the other one is the problems that we run into with different biases. As a reminder with confounder, so a confounder is what happens in an observational study when you've got a labeled exposure and you're looking for an outcome. And you get worried because there isn't a random assignment, is that you may have other things that track along with what you have labeled as the exposure. And then the problem is that it may be those other things, those confounders, that are actually causing the outcome of interest, and you may not realize it if you didn't think to measure that and see if they are in fact associated with what you have labeled and are studying as your exposure. And the reason that RCTs are so helpful with that is because of the randomization aspect of that. So they don't get rid of confounders. The confounders are always going to be there. But instead, as in observational studies, to where people, because of what they are doing, or providers, because of what they're doing to patients, that's what's driving what happens, this exposure. You are randomly assigning people to whether they are going to get exposed or whether they're not going to be exposed. And so your confounders are balanced in either group. And so you could almost think of it as they're canceling each other out. So age is a really good example. That's a confounder for almost everything that we think about. And you don't have to worry about there being older folks or younger folks in one group versus the other. You're randomly assigning them. So assuming that you have enough subjects and that you've done this correctly, that should balance on either side. And so should cancel out those effects. So that's one way RCTs help dealing with that. The other concern that you have are biases. And biases, we've talked about this before. A bias is just you treat somebody differently because of the group that they're in. We use that informally in lots of different ways when we use the word bias. It's the same in biomedical research. And it's not always intentional. Subjects themselves can act differently because they know that they are in an intervention group or if they're in a control group, so to speak, and investigators can do the same thing. And why RCTs are helpful is that if you can blind everybody involved in a study, then you don't know which group somebody is in. So you can't have an issue with a bias, at least the vast majority of what we look at and describe as biases in biomedical research. You can't have one if you don't know which group somebody's in. And so the blinding really effectively prevents the vast majority of those. So that's why those are such strong studies, why we describe them typically as the gold standard in research. So we'll keep those things in mind and think about how that works out in this investigation. So to go to this study, we'll look at the inclusion criteria first of all. So to go through those in order. So the authors here looked at women between the ages of 14 and 40, and they based their diagnosis of PCOS on the Rotterdam criteria. However, they had a couple of other things on top of that. And in a second, we're going to get Stan's input on this because I think it would be helpful to get his insight into why maybe the authors chose this and what the implications would be. But one is that the patients had to either have obesity, so have a BMI that was 30 or above, or you could have a BMI between 27 and 30 if you also had hypertension, type 2 diabetes, or dyslipidemia, so some metabolic impact of the weight. So that's one thing we're going to ask Stan about here in a second. And then as a second issue, the author specified that for women who were within 8 years of menarche, they had to have both ovulatory dysfunction and hyperandrogenism in order to qualify for the study. So Stan, can you walk through this again? There's a couple of issues here, but help us understand why these inclusion criteria might have been chosen as it relates to PCOS, and even specifying that for some women who were in the overweight category, they also had to have some of these metabolic complications, so to speak.
Well, my understanding with regard to the evidence of hyperandrogenization and ovulatory dysfunction, those are the NIH diagnostic criteria for PCOS. And so requiring that just means that they have to have PCOS. As far as the selection from among this group, it was my understanding that the cardiometabolic, diabetic, renal, and so on changes were not permitted in this group. They were to have simple PCOS.
We'll move on to think about the exclusion criteria as are listed here, and there were several, and that included individuals who had uncontrolled hypertension, if they were pregnant or lactating, if they used sulfonylureas or insulin for their diabetes, if they had kidney disease, glaucoma, or had a known allergy to the medications that were involved here, Metformin and Topiramate. And the procedure that the authors used, it initially involved a series of visits that we're going to walk through. And after I do this, we're going to yet again get Stan's input on this. So the first visit, which actually happened several months before the investigation truly started, involved an interview. And then importantly, if the women were on oral contraceptive pills, that those were stopped. At a second visit several months later, some baseline labs were drawn. And then these women were started on a progesterone-only OCP. And additionally, if they weren't already on metformin, then metformin 850 milligrams was started. There was later a third visit, and this was the point at which the subjects were randomized to receive Topiramate. And of note, there were some different doses. We'll hear about that from Na. There was also an escalation plan of the dose of that medication if the subject lost less than 3% of their weight. Finally, something that happened for all the subjects, everyone was recommended to use a 20 kilocalorie per kilogram diet. And also they were instructed to maintain their current physical activity. And then as we'll hear, there were periodic assessments throughout to measure some of the outcomes that we're going to get to in just a second. Before we do that though, Stan, another question for you. Curious about your thoughts on this protocol as the authors outline it. Particularly, I know you had some interest in this choice of putting all of these women on a progesterone-only OCP. So give us your thoughts on that, if you would.
Well, during my entire time in practice, I took people off progestin-only BCPs because I wanted to ensure that ovarian function was suppressed, because hyperandrogenism is ovarian in origin in all of these patients, and suppressing ovarian function would uniformly bring their testosterones down well into the normal female range. If I were going to achieve any effect that was androgen induced, I had to be sure that ovarian function was suppressed. So if you use an estrogen containing oral contraceptive, you will generally suppress the androgens by suppressing the ovary. I must say recently, in the last 8 or 10 years, the low dose estrogen oral contraceptives have been shown in obese women, not necessarily PCOS women, but in obese women in general, to be less effective in preventing pregnancies because they are less effective in suppressing ovarian function. I was careful not to use the lowest dose, 20 micrograms of ethinyl estradiol, in the birth control pills that I used, because I felt that you needed at least 30 micrograms to really guarantee that ovarian function was suppressed. I was not happy with the desogestrel because that does not suppress ovarian function similarly. They decided to really follow these patients carefully, and they were making phone calls weekly. That's great for a study, but that subtracts from the ability of the study to be representative of what might be expected in practice.
I really appreciate those comments from Stan. He pointed these out as we were doing our initial analysis, and I found it really helpful to think about it that way. And the authors will get to this in the discussion, but they actually described their use of a progesterone-only birth control pill here as a strength of this study. And I think that makes sense from the perspective of, well, you're not going to have the estrogen effects on many of the lab parameters that are being looked at here. And so I think from that argument, definitely makes sense. You can understand why they would do that. But Stan's point here, I think, is a very good one, is that it perhaps introduces a situation that is not very similar to the patients that we take care of, because unless a woman has a reason to not be on oral estrogen, and certainly that exists, but most women don't. And so we're often trying to do that for exactly the reason that Stan outlined. And so perhaps this population then becomes a little bit different than the usual population that we may be taking care of. So I think absolutely something that we have to keep in mind as we interpret these results, and particularly as we try to think about how they might apply to the patients that we take care of. We will come back to that here at the end of our discussion. Now on to the outcomes that the authors are reporting here. So they've got a primary outcome and then secondary ones as well. First, for the primary outcome, they are going to look at the percentage of change in body weight from baseline. So now help us out. This is your wheelhouse. It makes sense as an outcome here. As somebody who has expertise in obesity management, is this what you would want them to look at, or would there be a different preferred way to try to understand effects of weight loss in a population?
100%. I mean, if you look at all the recent large weight loss trials, like the STEP trials, SURMOUNT trials, OASIS, retatrutide trials, I mean, all the primary outcomes now for these weight loss medications are to look at the percent body weight loss. So that was good that they did that. I mean, obviously, the major differences are these other trials are much larger. We're looking at minimal 300 patients. Oftentimes, these larger trials have over 1,000 patients, and the time frame was also longer, at least 12 months to 18 months, whereas this trial really just looked at up to 6 months. So some differences, but I think it's very reasonable. They picked the right primary outcome for this kind of study.
So they're asking the question that we definitely want the answer to. A bunch of secondary outcomes. Now, I was going to give us some of the details on that, but briefly, just to put them in categories, they were looking for changes in clinical, cardiometabolic, and hormonal parameters. So more on that shortly. Finally, just a brief word on some of the statistics that are employed here. One thing that I really like that the authors did is how they describe their sample size calculation. That's a very standard thing to do in RCTs. You've got to understand, well, how many subjects do we need to enroll to be able to prove that we have a change here if it's the change that we anticipate. One of the things that I really liked is they provided a citation of the weight loss estimate that they were anticipating from this study. So I think it was really helpful to be able to look and say, okay, so they weren't just making up a number. This wasn't an estimate that they pulled out of the blue, but they had other data that they were pulling into this as a key component of their sample size calculation. Finally, as again, the expectation, the gold standard for RCTs is that they use intention to treat analysis, and that's what the authors used here.
I would like just to add one other comment, and that is the use of 850 milligrams of metformin. That's a low dose. We routinely went up to 2 grams. We raised it from 500 milligrams to 1,000 to 1,500 to 2,000 over the course of a few months. It was my experience that people did better on at least 1,500. So it's something to keep in mind.
And the authors in their discussion do point that out as a potential weakness of their investigation, but good for stand-up point that out here while we're still thinking about that. Okay, so enough on the methodology. We're going to move now into the results, and Na is going to walk through what the authors report.
All right, let's go. So if you look at figure 2, it shows that 61 participants were included, with 31 in the metformin placebo group and 30 in the metformin topiramate group. So when you look at the table 1 breakdown of all the participant characteristics, you'll see that these participants were predominantly white. They had a mean age of 26, so they're pretty young. Their PCOS phenotypes were mostly A and B. They had a higher level of education. And as Stan pointed out earlier, the median metformin dose was only 850 milligrams, although it did range from 500 to 2,550 milligrams as well. So going back to what Chase was also talking about earlier, is this our patient population? Stan, is this typically what you saw in your clinic for PCOS women?
Well, I think that this group of women was heavier than my average patient, just because they're just different people from a different environment. But an average BMI of 35 is pretty high. What about in your population? Are they all up there?
Well, I see a lot of women with obesity. So yes, the women that I do see that also either come in with PCOS or I happen to diagnose them with PCOS tend to be of this BMI range.
On the average, mine were somewhat lighter.
So the attrition rate was 26.2%, which I thought was pretty high. Loss of follow-up were seen in 11 patients from the metformin placebo group and 5 from the metformin topiramate group. Stan, do you feel like this is a high attrition rate as well? And why would the authors expect this?
I don't know. I think it's a high attrition rate, and it really affects, because of the method they use, they have a lot of people who did not complete who are included in the statistics. So I think it subtracts from the validity of the study.
I agree. And if you look at figure 3, this tells us the primary endpoint, which is weight change from baseline. And by looking at the graph, we see that the metformin topiramate group did show greater mean weight loss at 3 months and 6 months compared to the metformin placebo group. And this is statistically significant with a p-value of 0.03. So at 3 months, we're looking at a loss of 3.42% in the metformin topiramate group versus 1.65% in the metformin placebo group. And then when you look at 6 months, the weight loss was a little bit more at 4.5% in the metformin topiramate group versus 1.41% in the metformin placebo group. So Stan, were these the kind of results that you would expect to see?
Well, yeah, and that much weight loss over 6 months, I probably saw a lot, but those weight losses didn't persist, and I never got to using GLP-1 drugs in PCOS because I ran out of practice before they became that popular. So I did not have that experience, but I think that we did achieve this much with metformin and diet alone in a lot of patients, but certainly not all.
And then we jump to table 2, looks at the secondary endpoint assessments of clinical, hormonal, and metabolic variables at the 6-month follow-up. And just as a general trend, we saw that testosterone and androstenedione decreased across both groups. Triglycerides and LDL also had modest reductions across both groups. CRP decreased more in the metformin topiramate group, did not change much in the metformin placebo group. Waist circumference also showed a greater reduction from 107.6 centimeters to 101.7 centimeters in the metformin topiramate group compared to the metformin placebo group, which only showed a slight reduction from 102.2 centimeters to 100.1 centimeters. We also saw improvements in the SRQ-20 scores across both groups. So, Stan, what do you think of these findings, including that there were improvements in both groups for some of these outcomes?
Well, I think that taking care of the patient was important, and I think there was a diet-related feature. It was my experience that metformin reduced the intense need to eat that a lot of these patients had, so they were able to diet if they actually decided to diet much better on metformin. And I think that played a significant role.
So the authors also mention that increasing topiramate to 100 milligrams at 3 months in those with less than 3% weight loss did not provide added weight loss in the next 3 months. Post hoc analysis at 6 months showed that participants who lost more than 3% weight from baseline show significant improvement in modified Ferriman-Gallwey score compared to participants with less than 3% weight loss. Authors also reported mild adverse events with paresthesia, more commonly seen in the metformin topiramate group. 2 participants from the metformin topiramate group withdraw from this study due to adverse events, specifically due to drowsiness and paresthesia. In the metformin placebo group, 1 participant withdrew due to skin rash and 2 others withdrew due to hypermenorrhea. Otherwise, no serious adverse events were reported. I'm going to turn it back to you, Chase, to wrap it up for us.
We're going to start with where the authors start, and that's a couple of quotations related to the summary of their findings. So we'll start with one quote here where the authors say, "In this randomized controlled trial, the combination of metformin and topiramate was superior to metformin plus placebo in reducing initial body weight over a 6-month follow-up period in women with PCOS." And then a second quotation, "To the best of our knowledge, this is the first randomized clinical trial to evaluate the effects of topiramate added to a metformin regimen on weight loss in women with PCOS." The authors then go on, as is typical in these discussions, to compare it to other literature that's out there, and they point out that there are similar findings from other RCTs that looked at adding topiramate to metformin in participants with type 2 diabetes, and that was where they got some of their initial estimates from. I want to go back to a point that Na has already made that the authors pointed out in their results. They come back to it in their discussion, and that's this finding that participants who experienced a greater than 3% weight loss also had better hirsutism scores at 6 months. Stan, I was kind of interested in your thoughts on this one and how this might relate to this idea of, is it possible that really trying to get at least part of the underlying pathophys of PCOS with that weight gain, that if you can reverse that, then maybe you are ameliorating some of the hyperandrogenism manifestations. But would you see that similarly, or do you have a different take on that post hoc finding that the authors reported?
I was looking at the total testosterone to see if the regimen suppressed their testosterone, and the placebo went from 0.51 to 0.39, and the treated went from 0.6 to 0.43. So they really didn't suppress testosterone. That's further evidence that a progestin-only birth control agent doesn't suppress testosterone the way an estrogen-containing agent does. So I was a little surprised that they had so much success with the hirsutism, but that's the way it is. I did look up an effect of topiramate on androgen function, and it turns out that there are a couple of papers using mice showing that in high dose topiramate suppresses testicular function, but there's nothing in female. So there's no way of saying that it has any biological effect on androgen production in females, at least from the literature I was able to find.
Yeah, certainly an interesting finding that the authors report, particularly since we don't fully understand as to how that might happen and don't see clear correlations with lab changes there. The authors go on to report their limitations. We've touched on some of those already. They list that they had a small sample size, that there was a fairly high attrition rate. They point out that they used primarily low doses of metformin, and that they also did not have the ability to test for a higher topiramate dose response. They list some strengths, and they point out that their groups were fairly similar at baseline. They had very close monitoring. Stan's pointed that out already for us. And there was a high medication adherence as well. And then finally, as we spent a while talking about, they list as a strength the use of progesterone-only pills for contraception. The authors then move into their conclusion, and they start with what I would describe as a summary, and I'll quote them here where they say, "In this study, we found that topiramate added to metformin and a low-calorie diet provided an effective and safe option for weight management in women with PCOS with few mild adverse events." And then moving on to what I would describe as an implication, the authors state that in the era of new effective drugs for treating obesity, topiramate with metformin can be an option for women with obesity and PCOS, considering its low cost, reports of long-term experience with this medication, and ease of use. Okay, we're going to wrestle with those as we wrap up this episode. And the first thing that we're going to think about is just the quality of this report overall. In a minute, we'll get to whether we think this should change what we do. But before we do that, Noah, let's start with you. You spent a while wrestling with this article, thinking through a lot of these components. But what is your sense of the overall quality of this study?
I think the overall quality of the study probably could be better. I think there definitely is some strengths, which you've mentioned earlier, and Stan mentioned that too, the close monitoring. I think that's very important. The patient population, at least, is very similar to mine, so I found that to be a strength. But unfortunately, to me, the samples patient size was just too small. You know, with all these larger weight loss trials coming out with thousands of patients, I mean, this is just such a small patient population. That part to me is unfortunately not a good quality for this study.
Yeah, impressive that the authors are still able to show some differences in these groups. But yeah, exactly as the authors point out, that definitely a potential limitation of the small sample size here. Stan, thoughts on the quality of this report overall?
Well, I think they did what they thought out as the best way of handling this. Well, I have some disagreement with, for example, the selection of just an only birth control pill, but I can understand why they did it, and I think that the result is essentially valid. I do think that we're moving into an era where very expensive weight loss drugs are not going to be available, even in the United States, to millions of people. The idea of a trial of a much less expensive drug is not a bad idea. And for patients who don't have side effects, who feel comfortable taking it, they may get some results that are useful and worthwhile in people who will not be able to afford the better drug. So I think it's worthwhile. It offers an opportunity for people who are doing practices, who have practices that will not permit the use of expensive medications.
Yeah, let's further investigate this idea of whether this should be changing our practice. So, let's come back to you. You see a lot of patients for weight management. So give us your thoughts. If you're seeing somebody, a woman who also has PCOS, going to be thinking more about this, or maybe not yet convinced and not going to change what you do, give us your thoughts on that.
I will say, first of all, that so much of what I've learned from PCOS was from Stan. I don't know if you guys know this, but he was my mentor when I was a fellow back at UCLA. And he taught me everything I knew about PCOS and really encouraged my passion for this field, which led to obesity. So for me, because I see so much PCOS women with obesity, and as Stan alluded to earlier, I mean, the cost of some of these new GLP-1s, it's just either unaffordable or the side effects are just too much, and we need to have alternative medications that patients can tolerate. So for me, I've actually been prescribing Topiramate off-label for a long time now, either with or without phentermine, sometimes in addition to GLP-1. So I do all sorts of combinations, cocktails, ultimately treating obesity like it is a chronic disease. And sometimes we need multiple medications to really provide the best optimal treatment. So for me, it doesn't change my practice because I've been doing this for a very long time. And I do feel that, the reason I really gravitated towards the study was, as Stan pointed out earlier, is I think we need to have more options, basically. And I feel like this is a great, pretty low cost, low adverse effect treatment option that I think more physicians can now think of. And I think this study, as small as it is, and as much as it has its own limitations, I feel like it at least gives attention to this oftentimes overlooked drug that we can potentially add and use in our patient population.
Yeah, particularly nice that in the era of more and more individualized medicine that we can actually tell to somebody, hey, this medicine's been investigated, and somebody who is at least similar to you in several key components of not only having obesity, but also having PCOS. Okay, Stan, let's finish with you. You've given us some of your thoughts already on that. Hey, this is something that we should at least think about in our practice. But why don't you just expand on that? And also curious on some of your thoughts. I know you had mentioned when we were thinking through this earlier about keeping in mind the idea of a treatment trial and how sometimes that is going to be different from permanent management. Why don't you just wrap us up by more thoughts on whether this should change our clinical practice?
Well, I think that there's a subset of patients who do not do well on diet metformin alone, and that's maybe 80% of the total obesity group, and who cannot afford GLP-1 drugs, and a trial of Topiramate may be just perfect for them. And if it works, fine. If it doesn't work, you can always stop it and try something else. So I think, Na has been doing it. I didn't know that Na was already into it. And I think it's a good idea. And so I think that some endocrinologists will look at this paper and change their practice, and probably for the better. As long as they don't insist on people who have side effects to taking the same drug, they can always stop.
And with that, I would like to thank Na Shen and Stanley Kornman for joining me for this month's edition of Endocrine Feedback Loop. I hope that you all learned as much as I did today and that you will join us again next month. And now you're in the loop. This has been Endocrine Feedback Loop. Endocrine Feedback Loop is brought to you by the Endocrine Society with production oversight by Brandy Brown and Andrew Harmon. If you want to like and subscribe, you can find us on Apple, Spotify, or wherever you get your podcasts. We'd love to hear your feedback on this episode or the podcast itself. Please email us at podcast@endocrine.org.
Endocrine Feedback Loop is a free service of the Endocrine Society. To learn more or to become a member, visit the Society's website at www.endocrine.org.